So I typically don't work up bedwetting until around age 5. The reason being is 75% to 70% or so will become dry at age 5. And so that's why I don't do work up until age 5. After that, the remaining 25 to 30%, 15% of that remaining 25 to 30% will resolve each year. And there are studies, multiple studies, that have shown that eventually bedwetting will resolve on its own. So unfortunately, there's really no magic medication that can speed up that process. The only thing that kind of have some retrospective data that support
Priceless, take it to the moon. Priceless, one day will be soon.
Hi everyone, welcome to another episode of D-Talk with Dr. Pham. So I've been getting a lot of requests from parents to discuss bedwetting or enuresis. So before we go into kind of the cause of bedwetting and why children and parents want to be dry, let's just go over a little bit of statistics. So I typically don't work up bedwetting until around age 5. The reason being is 75% to 70% or so will become dry at age 5. And so that's why I don't do work up until age 5. After that, the remaining 25 to 30%, 15% of that remaining 25 to 30% will resolve each year. And there are studies, multiple studies, that have shown that eventually bedwetting will resolve on its own. So unfortunately, there's really no magic medication that can speed up that process. The only thing that kind of have some retrospective data that support the decrease in time to resolution is how motivated the child is and how regimented the parents are in helping the child achieve that. But before we talk about it, let's go into basic anatomy of what exactly causes bedwetting, and then we will talk about treatment and side effects and stuff like that. So basically, the body has a kidney on each side, and so I'm no Monet, but I think the pictures will get the point across. So basically, these are your kidneys, and then this is the ureter, and the ureter is the tube that connects from the kidney to the bladder so that urine flows down here. And then this is the urethra, and then the urine will then get excreted. And then this is the brain, and this is spinal cord. So up in the brain is a center called the pons micturition center or the pons voiding center. And so that area needs to mature. And what that area does is it relaxes the bladder at night so that it can accommodate more urine so that the bladder doesn't contract, causing the accident. And also it allows the bladder to relax, but it also wakes the child up if the bladder is so full that it will wake the child up to go to the bathroom. And typically by age 18, pretty much I would say in my patient population, and generally 99% will be dry at 18. So that's why you're not going to see a bunch of 18-year-old college students have accidents at night unless, they went to a frat party and was drinking. Well, then there's nothing I can do about that when you're passed out from alcohol, which I don't condone, okay? You need to be 21. 18 is not the age to drink. So as a physician, I do have to tell you that. So then at night, what happened is, and it's not just at night, but at night, basically blood gets filtered or gets pumped from the heart, and then the kidney works like a Brita filter. It will then filter that blood, and then all the excess water and waste like sodium and all sorts will then get concentrated and gets turned into urine. And then hopefully you can see it, but the urine will then come down here. And then basically once it reaches a certain capacity, whatever that capacity is, and there's a formula that we use to kind of generally figure out at what age what that capacity is. Okay, so for those who likes to calculate stuff, the general formula is, and this is really for basically above age 2. Under age 1 is a little bit of different formula, but above age 2, how to calculate the general average bladder volume is age plus 2 times 30. So if you're 5, you just add 2, multiply it by 30, and that's the average bladder capacity. And so at night, once it reaches that certain capacity, if the pons micturition center, which I'll just mark as red up here, if that area is not mature yet, then what happens is instead of relaxing the bladder, it's gonna allow the bladder to contract. And on top of that, it doesn't wake the child up. And so then that's how the accidents happen. Because what it does is that when the bladder reaches a certain amount, it sends a signal to the spine, which will then send a signal back to the bladder and another signal to the bladder neck to tell the bladder neck to open up and then the bladder to contract. And then that's how urine empties. So if the pons micturition center or the voiding center is mature, it will actually wake the child up and prevent this contraction so that no accidents happen. Now, unfortunately, there's no medication that can speed up this process. If there was, I would be a billionaire by now. And so unfortunately, the only medications we have now that are FDA approved, really all it does is keep the sheets dry. But that's very important, and I'll go into that a little bit later because it can affect a child's psychological aspect and it can interfere with a patient's learning and all that, because a lot of time parents would time it where they would wake the child up at 1 or 2 to go use the bathroom so that the accident doesn't happen. And to me, I don't like that, because once you wake someone up, they have to go back into, deep sleeping, and then, they're going to be tired the next day. And to me, that'll translate into poor, work, academics the next day. So I prefer if the child can stay dry without having to wake up. And so at night also, the problem is the body is laying flat, so you're actually not working against gravity. So more blood now is going to get pumped into the kidney, so the kidney is actually going to filter a lot more urine at night. And that's why you notice in the morning when you wake up and urinate, there's a lot more urine than during the day, because during the day, when you're walking or sitting, you're actually not working against gravity. You're working against gravity. And so basically not, the blood that's getting sent from the heart to the kidney is less than what it would be at night. So generally speaking, what I do with these is if a child is bothered by it and or a parent is bothered by it for whatever reason, psychological, they want to keep the sheets dry, there's hundreds of reasons why. My job as a urologist is to figure out how I can make them dry until nature takes its course. And so, a child shouldn't be punished because they wet the bed, because it's not really their fault, okay? Because the pons micturition center has to mature, and that's something that nature just has to take its course. And there's no medication, like I previously mentioned, that can decrease the time to resolution. All I can do as a urologist is to help keep the sheets dry so that it doesn't interfere with their learning and their psychological well-being and all sorts. In a 5-year-old, they may not care as much, but if you have a 10-year-old, they may care a lot more, because they're going to get to miss sleepovers, going to camp, just because they don't want to have an accident. So currently, really the only medication that is approved for bedwetting is something called desmopressin. And what desmopressin does is it just kind of slows down the kidney from excreting water or urine at night to not reach that trigger point. Now, what is that trigger point? Well, there is a test that we can use to find out, but to me, it's a fairly invasive test. It's called urodynamics. Or you can do a voiding cystourethrogram. But what it does is it requires you to put a catheter in. And I don't know, I personally never had a catheter put in, but when I do put in catheter, it hurts. And so you actually have to put a catheter in, and then they have to infuse you with contrast, and then they can measure when the bladder actually contracts and pressure and all that. In the beginning, my thoughts were you really need to have it, but as time, move on, I don't really feel like that's really a test that is needed. For me, the workup for bedwetting is if there's a history of diabetes, I always make sure that is it because the child has diabetes. And surprisingly, we have seen a lot of kids with diabetes that just went undiagnosed. And then with that, then the source is the diabetes and maybe not the voiding center. And then if there's reason to believe that there's some sort of anatomical issues such as vesicoureteral reflux or whatnot, then I will order the appropriate test. And so sometimes I will order an ultrasound to make sure there's not any underlying anatomical issues. And then I always order a basic metabolic panel. And the reason why is desmopressin really is your only FDA approved medication to use to help with bedwetting. But by retaining water, if your sodium is low, it can cause you to have a seizure. Now, have I personally seen it? No. The ones that this really occurs in are patients that actually don't make the hormone desmopressin. And so the dosage that they get is 3 to 4 times what the recommended dose is for bedwetting. And so back to this. So if a child comes in and they're motivated, they're like, Dr. Pham, this bothers me. I really want to be dry. And it also bothers the parents because they don't want to have to keep cleaning the sheets or whatnot. Then what I do is I do conservative measures first. And one of the things I do is I have them drink most of the fluid, about 80%, in the early morning. So when they wake up, until about 3 or 4. And why do I do that? I do that because if they drink consistently throughout the day, then when they get home, they don't get super thirsty because their thirst center doesn't get activated. So then they're not ending up drinking a bunch of fluid, which will take hours to get, for the kidneys to get rid of it. And so children, when they get home around 3 or 4 and they're chugging down, 2 of these, and then they go to bed at 8, well, the body is going to try to get rid of all that fluid at night. And so otherwise, you can be bloated like a toad. And so first thing I do is I make sure that they drink most of their fluid early morning, early afternoon. And I also ask them during the day, do they have urinary frequency and urgency? Because in a 5-year-old, 6-year-old, they should be able to hold their urine for 3 to 4 hours with no issues. And then when they get the urgency or the urge to void, they should be able to suppress that until they go to the bathroom without having accidents. Now, if they can't do that, then that's what I call urinary frequency and urgency with incontinence without sensory awareness. That's a phenomenon that I will talk about in a separate episode. And sometimes you kind of have to treat both. But today we're strictly going to keep the talk to just enuresis. And so the second thing is I make sure they don't have constipation. So then there's something called the Bristol scale. I can't write backwards, so let me just kind of change it. And so this is a validated questionnaire that you can just Google, and it basically is just a stool scale from 1 through 7. And what the Bristol scale does is it tells you if the child has constipation. And it goes from a score from 1 through 7. And what you want is a score of 3 or 4. If you're having a lot of, and usually 2 weeks for me is enough to determine. So just because you have a bowel movement every day doesn't necessarily mean you don't have constipation. So that's where the Bristol scale comes in. And usually I just tell the parents, just put it on the patient's bathroom door, and then after they have a bowel movement, they just kind of mark, okay, do I have a 1? Do I have a 2? Do I have a 3? Do I have a 4? So forth, so on. If you're getting a lot of 2s and 3s, and especially if you're getting a lot of 1s and 2s, then that tells me that you have constipation. And with constipation, it can cause a phenomenon called bowel bladder syndrome. And what that is it's really a physical phenomenon where the bladder sits right here, the rectum sits behind the bladder, and then in between the bladder are nerves that control, and this is a simplistic view, but there's nerve that actually controls the bladder contracting and the P channel opening. And so when you have bowel bladder syndrome, what it does is the constipation actually is pressing on the nerve, causing the bladder to contract when it's not supposed to contract. And that usually will present as a child having to go to the bathroom every hour, every 2 hours. Or it can cause the bladder not to contract, but the P channel to open, causing bacteria to climb up into the bladder. And with stagnant urine, that can lead to urinary tract infection. And most of the time, it leads to urinary tract infection not causing fever. And that becomes important because when you have a urinary tract infection causing fever, that means that the bacteria has come up to the kidney. And then now, once the kidney is affected, it will then send off cytokines and all sorts of stuff that will set up a mechanism that causes fever. And so usually if it's a localized symptoms, the bladder serves kind of like a toilet. Basically, if you drink a lot of fluid, it'll kind of flush everything out. But if you look up something called bowel bladder syndrome on Google, you can read more about why constipation can make the nighttime wetness worse and can also cause daytime symptoms. And so daytime symptoms such as urinary urgency and frequency can cause along with the enuresis, or it can be isolated. And so, but back to this. So now if I have them drink most of the fluid, and then I also make sure that they don't have urinary frequency and urgency. So what I tell parents is make sure that they go to the bathroom every 3 or 4 hours, regardless whether they feel like it or not. And that's what we call time voiding, because I want to make sure that the child empties. The third thing I do is I also have them do, now this is if they have urinary frequency and urgency and are going to the bathroom frequently and all that. The third thing I also have them do is to make sure that they, after they urinate, just count to 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000, and then try to squeeze everything out just to make sure that they empty. And by doing that, it may not solve the nighttime wetness, but it will make the amount of wetness less. And that's conservative therapy. And there are children where I start them on conservative therapy, and then when I see them back, usually in about 4 to 6 weeks to see how they do before I start medication, they actually are dry. Now, are they dry because nature took its place within that time frame where the pons micturition center has matured and it actually relaxes the bladder so that the patient does not contract and have an accident, or it wakes the child up so that the child goes to the bathroom and doesn't have an accident? Now that I can't answer because, that could also be the case. But either way, if they come back, conservative measures were implemented, and then they end up doing well and they have no accidents, well then problem solved. Then there's nothing more that needs to be done. Now for the children that we implemented conservative measures, which is make sure they don't have constipation, make sure they don't have bowel bladder syndrome, make sure they don't have urinary frequency and urgency. Then at that time, those kids, I give parents the option of starting something called desmopressin. And so really enuresis is not a very complex disorder. All it is really decrease the urine or increase the capacity of the bladder or both, so that the end result, which is contraction of the bladder, does not occur. Because obviously the patient, if the pons micturition center is not mature, the patient is not going to get woken up unless the parents do that. Now, there are also bed alarms and stuff like that, but usually by the time parents come see me, they've already tried the bed alarms and all that. The only thing they really haven't tried is the fluid restriction, meaning that, or really I should call it a fluid shift. So because you still want a child to get at least a liter of water a day. And so really it should be called fluid shift, meaning that changing the fluid habit and then doing the double voiding and time voiding. Then at that point, then I give patients, parents the option of, do they want to start medication? And if they do start medication, then the first line of medication is desmopressin. And typically, I will start at a lower dose, which is 0.2 milligram, 1 hour before bedtime, and they can take it with a little bit of fluid. It's just a small pill. Now, they also have the nasal version, but I'm not sure if the nasal version actually works better. But I do know the cost is probably more. And desmopressin has been around for a very long time. It's a safe medication as long as you check the basic metabolic panel to make sure that their sodium is normal so that they don't end up with a seizure. And like I said, I personally have never seen it, but that is in the drug packaging. And the reason being is seizure can be caused by low sodium. And so when you use desmopressin, what you're actually doing is you're preventing the kidney from excreting a lot of water into the bladder so that it doesn't reach whatever capacity it's supposed to reach that causes the contraction. And so if the sodium is normal, then I would start the desmopressin. And usually I start off on a low dose unless the patient's already been started on it before, then then I'll go up to 0.4 or 0.6, which is the max. And typically, once they implement, in my patient population anyways, once they implement the conservative measures on top of the desmopressin, they will notice a change. Because typically when patients come see me, they were never told to kind of change their fluid pattern and the time voiding and the double voiding and all that. They're just really put on the medication. And if you don't change the fluid pattern, then the medication alone, if it doesn't work the first time, it's just not going to work the second time. I mean, that's literally the definition of insanity, right? Doing the same thing over, expecting a different result. And so what I've noticed in my patient population is when I do implement conservative measures on top of desmopressin, then they do see some improvement. Now, some patients will see more improvement than others. But when you really drill down to it, you'll know what, in my patient population anyways, what I really notice is that the days that they are dry are the days that they actually did everything that they were supposed to do. And then on days that they are wet or days that they are more wet because they did that day, they actually did not follow the fluid shift. And usually this occurs in children that play sports. And there's nothing I can do about that. If you're playing sports at 7 and you're dehydrated, last thing you want is the kidney to go in shock. And so those children, they're just gonna have to drink water, and there's nothing you can get around that. But once I start them on the medication and I max out on the medication and it's still not working, then the next thing I do, or in children that play sport, then, on those days, what I do is, like I said, enuresis is not very complicated. And so what I do is I will start a second medication. So we already start desmopressin, which will slow down the kidney from making urine. And then the second part would be if we can increase the capacity of the bladder. And there are drugs called anticholinergic. And one of the ones I like to use is called Vesicare. And that's the name brand. The generics called Solafenacin. And the last time I checked, I believe Vesicare, Detrol XL, it's either Detrol XL or LA, which is the long-acting version, and Ditropan ER are both on-label use now for enuresis or for use in children. And what these medication do is they're anticholinergic, and what they do is they're going to increase the capacity of the bladder. So we're attacking it 2 ways, right? Or 3 ways. One is to restrict the fluid as best you can before bedtime and, drinking it in the early morning, early afternoon, and then all the other conservative measures. Then the desmopressin will slow the kidney from making the urine. So we're going to decrease the amount of urine that actually gets into the bladder. Then now we're going to add another drug, which will actually increase the capacity of the bladder. So we're basically attacking it from three different directions so that basically the end goal is so that the bladder doesn't have a contraction until nature takes its course and the pons micturition center matures. Now, what I do after we start all this and the patient actually is dry. Well, once the patient is dry, there's no magic to it. If I only started them on desmopressin and they're dry, then what I do is I wait 3 months, usually around the holidays or when school is not in. Because my goal is always let them focus on school and not where the next nearest bathroom is, or have to change the sheets before school or whatever it may be. And so typically, once I start the medication and it's working for them, I keep them on the medication for around 3 months or 6 months, just depends. And then basically I just stop the medication either in the summertime or the wintertime. Now, keep in mind with desmopressin, when you initially first stop it, you're going to notice episodes of wetness at night. That doesn't count. You got to give it a few days for the body to adjust. And then if they're dry, then that's it. You're cured. Nothing else to do. If I stop the medication and then you're wet again, then all I do is I restart the medication and then we do the same thing. We wait until either the holidays or summer where they don't have school, and then I just stop the medication again and then see if nature has taken its course. And then so that's really the whole management of enuresis. It's really not complicated at all. The main points to take home is the pons micturition center just has to mature on its own. And at age 5, 70% to 75% will resolve, meaning that they will be dry at night. Of the remaining 25 to 30%, 15% will resolve each year. Now, there's no test that I can do to predict which one will fall into the 25 to 30% that won't be dry, and then which one will fall into the 70% that will be dry. What I do know is that usually daytime continence will occur before nighttime continence. And there's nothing wrong with trying alarms and all of that. It's really surgeon preference and talking to the parents. But in my experience, parents would rather not have to resort to alarms and having to wake the child up, which I don't like either. And so for me, medication is safe as long as proper tests are done to make sure that there's no abnormalities such as diabetes. And I usually just check a hemoglobin A1C if there's some concerns for diabetes or whatnot. And then always check a BMP if you're going to start desmopressin, because one thing you don't want is a low sodium and then you start them on desmopressin and then it can cause them to have a seizure because it can artificially lower the sodium by retaining water at night. And then usually I will just start off with desmopressin. I will slowly escalate it unless the patient's already been on it. And then if that still doesn't work and they have implemented conservative measures, which we talked about earlier, then I will add an anticholinergic. And typically in my patient population, around 95% will become dry. And rarely will I have a patient where pretty much I throw everything at them and they're still wet and the parents truly have implemented every single conservative measures. Then there may be a role for Botox, but I won't get into that because Botox is really not the mainstream for treating enuresis. It's really desmopressin, anticholinergic, and time. Now, if the patient has daytime symptoms, meaning that they have to run to the bathroom every 30 minutes, and bowel bladder syndrome has been ruled out with the Bristol scale, then I will start anticholinergic with desmopressin together because the anticholinergic, which all it really does is relaxes the bladder so that it can accommodate more urine. And then I will start that with the desmopressin so that we can treat both symptoms. And then if there's a child that I do start anticholinergic during the day because they're having to run to the bathroom every 30 minutes or every hour, then, there's a workup for that, i.e., make sure they don't have an infection and all that. And once we roll all that out, then I tell the parents how to do bladder training. And bladder training is very simple. All we do is you find out what their baseline is first. So like, are they have to go to the bathroom every 30 minutes or every hour? Then what I do is once I start the anticholinergic, then I tell the parents, okay, this week, let's just say their baseline is 1 hour. They have to go every 1 hour. And then if they don't make it to the bathroom in about 5 minutes, they will wet on themselves. Then what I tell parents is, usually either do it after school, because it's going to be very hard to do it in school. Either do it after school or on the weekend, where what you do is when the child has the urgency, the need to void, then see if they can hold it for an extra 10 minutes and then go. And then you try that for a week. And if they can do that, then the next week you try to hold it for 20 minutes. And so that's how you kind of train the bladder. And then basically by doing that, that's how you kind of increase the capacity. But that's really a subject of its own, and we can revisit that in another episode. So I hope this episode was helpful, kind of on the enuresis side. And then at least now, these are really the conservative measures are things that parents can actually just do at home first. And if all of that fails, then, then obviously seek medical attention. And, we can go into more depth about that. Okay. So I hope this episode was enjoyable and I hope it was informative. And if you do like it, please subscribe. We're on Spotify, Apple Podcasts, YouTube, Facebook, you name it. And so please hit the subscribe button, okay?
Priceless, take it to the moon. Priceless, one day will be soon. It's priceless, take it to the moon.